Our vision at the Gold Coast Primary Health Network, it's working together with healthcare providers and the community to build a world-class health system for the Gold Coast. We engage with and support general practice as the cornerstone of primary health care. General practice is a highly valued partner, and we continue to work together to improve services for our community. Yes, it's a lofty vision, but we think we're up for the task. So an overview of the Gold Coast. For those of you who don't know where we are, most people do. We're just over the border from New South Wales, so have the same issues that our colleagues who presented earlier do in regard to those cross-border issues. So southeast Queensland area, beautiful area of the country. So our opportunities, we have one local health district to work with, although we do also have 2 private hospitals. A lot of primary health networks have to work with multiple local health districts, which makes their job a lot harder than ours. We partner with our health district on a number of activities, including general practice liaison. We're lucky that our general practice liaison officer has a special interest in change management and a strong partnership on integrated care. Some of the barriers that we face in our area, we're one of the smaller PHNs with still a relatively large workforce. And that workforce tends to be transient. People come to the Gold Coast because they think it's going to this amazing place. Yes, it is, but it's not for everybody, and people move on. We have a high proportion of new practices opening, resulting in challenges to sustainable change. We have a growing population, especially in the northern corridor here. We also have a transient population. We have a high number of visitors in the summer months, but we also have a high number of visitors in the winter months. We get lots of people from Tasmania and Victoria that come up for the warmer weather. And we also have a little thing called the Commonwealth Games happening in 2018, of which we're trying to assist our practices to prepare for. I've already mentioned the cross-border issues that we have, as the same with northern New South Wales, where we have a lot of patients who, whilst they live in northern New South Wales, actually access services on the Gold Coast. So who are we? Our practice support team have a long history of supporting local general practices. We're lucky, our team have come through the divisions of general practice, through Medicare Local and now into PHNs. So whilst our name has changed, essentially the team is the same. We're therefore valued by general practice, and we're viewed as a trusted source of support and information. And for us, that promotes engagement, which makes our job that little bit easier. A lot of our colleagues in PHNs struggle with engagement in general practice because of the constant change that we go through as an organisation. Our practice support team, there's myself as the full-time program manager, and I have Chris, who's a fantastic support to me as my senior product officer, who also works full-time. We're also lucky that we actually have a general practitioner who works with us, who forms the lead for quality improvement and works with us for 8 hours a week. And then we have 3.2 FTE practice support officers across 6 staff members. Everybody on the team has a history of working in general practice across all roles, either as general practitioners, practice managers, nurses, or administrators. Our general practices are grouped into geographical areas, northern, central, and southern, and our practice support officers are allocated to support them in those areas. I mentioned earlier the growth that we're undertaking in the Northern Corridor. This does make this challenging, given that we only have that 3.2 FTE allocation. So we are having to redistribute some of our practices, which makes, when we do reallocations, that relationship it does become a bit of an issue. Each practice is allocated a nominated practice support officer, and their role is as a relationship manager for the organisation. They're the first point of contact for support, and most of the areas where we get requested for support is in accreditation, immunisation, digital health, close the gap, or the new integrated team care, and quality improvement, both clinical and business process improvement. We do our quality improvement utilising the PEN clinical audit tool. It allows us good access to population health data and provides important information for our needs assessment, as well as a number of other project activity, as well as the quality improvement work that we do. So who do we work with? We're currently working with 123 general practices who are eligible for the tool through compatible software. We currently have 186 mainstream general practices on the Gold Coast and about 21 special interest practices. Our aim is to engage with 80% or 138 of our general practices by June 30th of this year, with our forward vision to have 95% of general practices actively engaged in our tiered approach to practice support by the 30th of June 2018. A component of our practice support is our tiered approach to engaging practices in progressively higher levels of quality improvement, which is commensurate to their capacity. We start off at Tier 1, where we engage with all practices through communication, practice support for accreditation, digital health, immunisation, as I mentioned earlier, and they also submit monthly de-identified population health level data. From there, they move into Tier 2, which is data extraction and reporting quality improvement. That quality improvement focus is on data quality and clinical coding. They then move into Tier 3, which I'm actually not going to go into. Chris is going to do that shortly. And then we have Tier 4, which is a pilot for us at the moment, which we're using our innovative funding to work through. At this level, our practices are acting on detailed practice-level population health data to better engage with their patients at a population health level. Each year, we aim to move practices up to an upper tier to increase the number of practices completing chronic disease-focused quality improvement. We have the aim by the 30th of June 2018, 59 of our practices will be working at a Tier 3 level.
Let's hope I get the technology right too. Hasn't it been a great morning? And what a hard act to follow. Okay, Tier 3. This is our activity where we probably is the most intensive for our practice support and quality improvement. It's a targeted approach with a disease focus at the moment, but we are looking at moving into prevention and possibly cancer screening and other areas in the future. So what is quality improvement? Who does quality improvement? Hands up. Everyone does. You even do it at home, don't you? In daily life. It's part of our life. So we use quality improvement as the framework for change management in general practice. We've heard so much about the changes over the last few days, how much change we're experiencing in general practice, in funding, all sorts of things, the nurse's role. So it is really important to actually get really good at change management. And if you think about change management, I mean, I've worked in practice support for more years than I'd care to admit, that if you do the same thing over and over again and expect to get a different result, what have we got? Insanity. Yeah. So it's time. So we actually use the PDSA methodology, and I see we got IF people here. So yes, it's proven and tested. The only difference is when we've done a lot of collaborative work in the past, people got a bit bogged down in writing PDSAs. You know, that was a big drama. And what we really want is people actually to do actions. So our plan is called an action plan. And we get them to work through the steps very much that suits their needs and capacities and abilities at the time. And of course we have a dedicated practice support officer who becomes part of that team. And I forgot to do the slide right from the beginning. Okay, we're on to this one now. Okay, so when we start off, new practices in Tier 3, and they can either start at Tier 3 or work up through the levels. It just depends on the capacity of the practice. Then we start off with a GP engagement meeting. We call it GP because we really want the GPs to attend these activities to find out what's going on. Do we have any GPs in the room? Not at this one, okay. Because traditionally nurses and managers have been our key stakeholders. We work really well with them, and you all probably do too. We're the PHN people in the room. It's pretty easy to talk to them, isn't it? But for us, we need to work with the GPs because we're now trying to move out of data quality improvements into actually clinical metrics. So this GP meeting, we actually do a PowerPoint presentation. We usually provide them lunch. They love that. And we provide them a document which showcases all the work PHN does, and we do that in the PowerPoint. And we also give them a data report. And when they see the data, they're shocked. But the other thing too is they just didn't realise that they were giving data to us and that we could actually present back reports. They had no idea. And I think they only came to lunch because they thought we were reps. But that soon changed. So at that meeting, we get them to look at what their data's telling them. It's all about them starting to work in that process. It's not us about telling them. It doesn't take long for a GP to see where they need to make improvements in their data. From there, we actually get them to start thinking in quality improvement cycles. And we really want them to look at making small changes that they can achieve. And it's a bit like the East. When really looking at SMART goals are really East as well. But we need to make them easy, really easy and achievable, because if they do achieve them, they'll keep working. And if they try to eat the elephant in one bite and they get nowhere, they lose interest. It's really important that the accountability is assigned at this point. And our big focus is not just giving the nurses and the managers all the work. It's about what everybody in the team's doing. What can the reception staff do to help? What are the GP's role? And what's the practice support officer's role to help them achieve? So then we get into the doing part. And of course, the drivers are often the nurses in that role. The ones that communicate and share information, they're the ones that really help us get the data into us so we can feed back. And they obviously work very closely in the chronic disease management stage and care of patients. And I know we've talked a lot about bridging the gap in the last couple of days, but what we've seen happen is that the nurses now bridge the gap between the admin and the GP communications. So we're actually getting that teamwork starting to happen. It's early days, it's not happening in every practice, but we are seeing the changes occur, which is really encouraging. Quality improvement and making big changes is slow, it doesn't happen. But we're actually getting little incremental changes that are now making a difference. So our quality improvement cycle that we actually deliver runs over 3 months. So you start at 0 at the GP meeting, and about 6 weeks along the way we do what we call a touch point, and that's to assess the progress against those initial SMART goals. We only want them to set 1 or 2. When you get 10, you get no action at all, preferably only 1 goal. And it's something that we can measure in the data. There's no point setting a goal that you can't tell whether you've achieved it or not, or whether you're even making progress towards it. So it's usually a PACCAT data report that we can pull to provide that information back. But it can be a face-to-face visit. A lot of the new practices like that, or it can be just a phone call or an email. And we tell them, this is what you said you were going to do. This is what your data's now telling us. This is where you were, this is where you are. How's it going? And we get them to look at their progress at that point and whether they need to change direction, change their goal, or what they need to do. A couple of things that's actually happened along the way is that these I've often found now that we couldn't get GPs to come to these meetings. We don't expect them to be there for a long time, but just to pop in. They're actually sitting waiting for us to show them what their data's telling them. How did we go? And they're really keen to see their own improvements, or not. There was one practice we had that wasn't very good at coding CKD, and that was their topic area, and we know that that's not well coded. They all just sort of said, oh yeah, we'll code when we think it's appropriate. And it was actually after quite a long time, I went back and said, well, this is your data. Yes, you've identified maybe 30 or 40 new CKDs patients, but you've still got 120 indicated. And when we broke it down, they actually said, they all talked about it, and they said, well, I code from stage 1. No one said, no, I never do it until stage 4. And the consensus around the room was, they're all going to do it from stage 3. I can't wait to see what their data is going to show in the next time we review it and see whether they've achieved that. So when we get to the ACT stage, it's not a matter of, oh, well, that worked, let's move on to something else. Something that we haven't done well in the past is that if you find something that works, then make sure it stays working. And we really encourage all these great work to actually be embedded into business as usual. We want policies and procedures, we want orientation induction, we want the knowledge and this information to stay within the practice, not walk out with the people when they leave. We've had some small clinical improvements, nothing major really, but I think the biggest result we've had is that increase in team approach. It's really vital that we actually get everyone working together and everyone working to the scope of their expertise. Nurses doing nurses' work, GPs doing GP work, and admin staff doing the admin part of quality improvement. In the last 9 months, we've had 108 general practitioner interactions at these meetings. For the whole of 15-16, we had 60 GPs attending these meetings, so we are actually getting a message out.
So what does the future look for us at Gold Coast PHN? We currently have a draft practice support model that's aimed at enabling high-performing primary care. It's currently being reviewed by our Primary Healthcare Improvement Committee, which acts as our practice support advisory committee. This is made up of GPs, practice managers, practice nurses that inform and operationalise some of the ideas that we have. It aligns to Bodenheimer's building blocks of high-performing primary care and promotes and supports the process required to implement population health management with the triple aim measuring outcomes. Having heard the importance of sustainable change, we envisage that this model will support Gold Coast PHN as the facilitator of change, with practices taking responsibility within a team-based approach to achieving high performance with strong clinical governance. So what else are we moving to in the future? We're looking at a heat map to allow us to benchmark our practices. This will allow us to focus support to where it's needed. It'll identify which practices are leading improvements, and it'll allow us to then analyse their results and their actions and outcomes, which will allow us to support practices where achieving actions and outcomes is more challenging. It'll also foster peer-to-peer support. Benchmarking practices against clinical metrics for their focus area, and the example we've got here is for diabetes. We use the RACGP standards for quality and safety as a guide to the work that we do. It'll also allow us to utilise and predict the next group of practices to engage at a Tier 3 level. And again, as I've said, these are diabetes. So here, didn't want to do that. Here you can see, obviously, practices that are where they're not working towards the 45% benchmark, and then practices where they're doing really, really well. Okay, so in conclusion, primary care generates rich data, but data is only the foundational element of the improvement process. It's the action of taking this data to inform care that will ensure improvement in the quality and safety of care provision to patients. With that, I'll leave you as practice nurses to ponder what's your role in quality improvement. Thank you.